Welcome back to another episode of A Conversation With. We are happy to have you here with us once again. Today we've got another great talk to share with you, this one with Dr. Sarah Wakeman, and we got to talk about addiction in the media. Dr. Wakeman took some time to dispel some common addiction myths that are often perpetuated in media reporting around substance use disorder. She talked about her collaborative project, Changing the Narrative, a network of reporters, researchers, academics, and advocates who come together to share resources and information around addiction and addiction treatment. Dr. Sarah Wakeman is the Senior Medical Director for Substance Use Disorder at Mass General Brigham in the Office of the Chief Medical Officer. She's Medical Director for the Mass General Hospital Program for Substance Use and Addiction Services, Program Director of the Mass General Addiction Medicine Fellowship, and an Associate Professor of Medicine at Harvard Medical School, as well as serving on the American Society of Addiction Medicine Ethics Committee. Her research interests include evaluating models for integrated substance use disorder treatment in general medical settings, low-threshold treatment models, recovery coaching, physician attitudes and practice related to substance use disorder, and screening for substance use in primary care. All right, let's get into today's conversation with Dr. Sarah Wakeman. I'd love to kind of have you share a little bit of your journey. And we talked about this a little bit before, but tell me about what your path to addiction medicine looked like. What was it that steered you in this direction in your career?
Yeah, so it was a bit of a winding journey initially. So I decided I wanted to be a doctor apparently when I was 3 years old, according to my mom, when I got a Fisher-Price doctor kit as a gift, and then sort of never let that idea go, even though I didn't have any doctors in my family. So it came a little bit out of the blue. But throughout sort of school and high school, I continued to want to be a doctor. I volunteered at a children's hospital in high school and actually thought I wanted to be a pediatric oncologist, so a doctor who takes care of kids with cancer, which is pretty far afield from where I ended up, and went to a combined 8-year program for undergraduate medical school at Brown. And through that journey, I think had always had sort of a passion for caring for people who'd been made vulnerable by systems and sort of left behind by our systems of supposed care, and got interested particularly in HIV as I sort of came of age during the era where I think as a medical student, if you cared about social justice and wanted to sort of work with marginalized populations, HIV and global health was a sort of pathway to do that had many of us had mentors who were doing that. We were sort of coming into school on the tail end of after the HIV epidemic. And there were books about really leaders in that field, like books like Mountains Beyond Mountains by Tracy Kidder about Paul Farmer, that were incredibly impactful and inspiring, I think, to young medical students. And so over the course of my medical school journey, kind of shifted to thinking I would do global health and HIV. And then had this sort of surprise and very transformative experience this summer between my first and second year of medical school, where I was working in the HIV clinic in the state prison in Rhode Island. And I met an amazing mentor who really changed the course of my career. And I think it's important to note how powerful mentorship can be in student journeys and coming into addiction. And he is a guy by the name of Dr. Jody Rich, who is an infectious disease doctor and does HIV care, but has also been one of the leaders in addiction medicine treatment and really bringing addiction medicine treatment back into the rest of medical care long before others were doing that. And so I started working with him and basically just wanted to be like him. I think as a young student, got incredibly inspired by his work. He'd done some seminal trials looking at treating opioid use disorder in the criminal legal system. He'd done sort of advocacy work around syringe access and naloxone distribution, overdose prevention, and was incredibly inspiring to sort of a young student. But I also got captivated by addiction itself and sort of as a field, the way really is at this nexus of medicine and psychiatry and public health and social justice and policy and all of these threads coming together in this space that has really been forgotten by the medical field for a long time. And so became more and more passionate about that work and still thought I was going to be an infectious disease doctor because that was sort of the pathway I'd seen my mentor take. But when I went to residency at Mass General Hospital and began my kind of clinical training as a resident physician, realized that the thing that I was most passionate about, sort of talking to patients, treating patients for, educating my co-residents about, was addiction medicine. And also came to see that it's an area of tremendous need, that we have a lot of amazing infectious disease doctors out there. And while we have many amazing addiction medicine doctors, we don't have nearly enough. And so it felt like a real area of opportunity where I could contribute and have impact. And so I ended up shifting. And I think it's interesting looking back, there's actually threads, pediatric oncology is also about being with with patients and families at a moment that can be really scary and isolating, and where you're facing this daunting diagnosis, and HIV similarly, that same sort of experience, and then addiction too. And so I think there are some common threads that weave throughout there, but ultimately ended up at a very different destination than where I started out.
Yeah, that's interesting that you talk about those similarities. I mean, you're a wealth of information on the topic of addiction, and we're going to talk about some of your work and projects that are helping to get this information out there, and specifically into the hands of reporters and journalists. But one piece of information you've discussed, and I'm interested in hearing more about this, you talk about the distinction between dependence and addiction. In fact, you wrote an article, it's on the NIH site, titled Drug Dependence is Not an Addiction and It Matters, in which you write, misdiagnosis of addictive disorders can lead to a cascade of negative outcomes. Can you tell me a little bit about the differences between addiction and dependence, and what are some of these cascading negative outcomes that we're looking to avoid?
Yeah, thanks so much for that question. I think it's a really important distinction, and one that much of the public and much of the medical community gets really wrong. So importantly, addiction, the hallmark of addiction is compulsively using a substance despite bad things happening to you. So despite negative impact on your health, your physical or mental health, your relationships, your ability to function and whatever roles matter to you. So it's really that use despite consequences that's sort of the defining feature of addiction. In contrast, physical dependence means sort of needing to take a medication every day or you'll get sick. And that is present for lots of chronic health conditions that we treat. So anyone who has chronic pain, who's taking opioid pain medications, will have physical dependence. Anyone who's on benzodiazepine for an anxiety disorder will have physical dependence. Anyone who's being treated for a seizure disorder will have physical dependence. Arguably, anyone who's receiving insulin for diabetes care, or levothyroxine for their thyroid disease, is quote unquote dependent on that medication. But they are not compulsively using their medication despite bad things happening to them in their lives. In fact, that medication is allowing them to function normally and be healthy. And that's really important when we think about addiction, because our two most effective medications for opioid use disorder are methadone and buprenorphine. And those medications maintain physical dependence, but people are not addicted to them because the medications are giving them their lives back, are helping them achieve remission and recovery, and allowing them to parent and work and not die from overdose and do all the things that reach all the goals that they might have for themselves. And yet there continues to be a tremendous amount of misunderstanding and stigma towards methadone and buprenorphine specifically. And a lot of that centers around this idea that you're just quote unquote addicting them to something else. And at its core, that's a fundamental misunderstanding of the difference between dependence and addiction. And so I think that's really crucial, because one of the most important ways we can tackle the overdose crisis is to expand access to medications like methadone or buprenorphine. And so long as there's misperception around the sort of role of these medications and stigma about the use of the medications, we're going to have a hard time getting to the types of treatment thresholds we need to in order to really combat the overdose crisis. So that's sort of one really important way it matters for us. There's other ways too. So one is, patients with chronic pain who have found great benefit from opioids have suffered too in the sort of opioid epidemic leading into the overdose crisis. There's been a real backlash against opioid pain medications. There are many patients who, are on very high doses of medications that we probably wouldn't start now based on the evidence we have, and yet forcibly tapering them off their medications or refusing to prescribe them their medications is absolutely harmful and leads to things like withdrawal, overdose, suicide, turning to the illicit drug market to find opioids, fracturing the patient-doctor relationship. And so I think this sort of misunderstanding and pathologizing of physical dependence as equating addiction or as being similar has also harmed patients with pain. I think the other sort of piece that has its tentacles in the work that we do is part of the way we drive this field forward is through research. And one way that we do research is using claims data sets. So sort of one way to understand how many people are getting treatment now, or, of patients with opioid use disorder who come into the hospital system, what percentage get medication treatment or are seen by an addiction specialist. All of these questions that we really want to understand are often based on diagnosis code data. And so they're based on a physician or a nurse practitioner entering a diagnosis code at the time that they're seeing that person. And then researchers on the back end, or health insurance plans, or the government then looks at all that data to say, oh, this is what we know about opioid use disorder. But it turns out that diagnosis code data is wildly inaccurate because doctors and nurse practitioners also are confused about this difference between dependence and opioid use disorder. And so there have been some studies looking at diagnosis codes where practitioners have entered in one of the codes that are meant to signify opioid use disorder, but they confusingly use the older terminology from the DSM-4 of opioid dependence. And doctors and other providers will frequently misclassify patients with pain who are on opioids for pain. So, for example, like an end-stage cancer person living with end-stage cancer who's maybe taking pain medication for that cancer will get a diagnosis code of opioid dependence, and then actually will get included in these large data sets that are trying to understand sort of the prevalence and treatment of opioid use disorder. And so it makes it very hard for us to understand sort of truly what's going on around opioid use disorder treatment in healthcare systems because of this misunderstanding and misdiagnosis. So I think it's really important just to be precise in our language, to be really clear about what we're talking about, and to understand, again, those defining features of addiction really have nothing to do with whether or not you're taking a medication every day, and everything to do with how you're functioning and whether or not you meet criteria for a substance use disorder.
Yeah, and this is a perfect segue into what I want to ask you about next, and that's a project you're involved with called Changing the Narrative. And this is really cool. It's a network of reporters, researchers, academics, and advocates that are coming together with the mission of helping journalists and opinion leaders provide accurate, humane, and scientifically grounded information on key issues surrounding drug use and addiction. That is awesome. Tell me about your work with this project, and why do you think that being part of this kind of collaborative network and this resource for journalists is so important?
Yeah, it's been a wonderful, totally unfunded mandate. So if there's any funders out there interested in supporting our work, we are always looking for support. But it really came out of, before the slow death of Twitter, it came out of a group of those of us working in this space sort of getting to know each other, and from multiple different perspectives. So people like me who are addiction medicine physicians and researchers, people with lived experience who themselves identify as being a person in recovery or a person who uses drugs, people living with pain, researchers and policymakers and legal scholars, sort of all realizing that we were seeing the same thing very commonly, which is that when the lay press or media was reporting on addiction, they were often falling into the trap of sort of outdated and inaccurate myths that really perpetuate stigma and misunderstanding about addiction. And that ranged from using terribly stigmatizing and inaccurate language to really reporting as if fact things that are frankly untrue. So, for example, the myth around that you can overdose from touching fentanyl, which is absolutely inaccurate, but continues to be reported on. Stories keep getting promulgated about it, and that just drives fear and misunderstanding and anxiety for first responders and for community members. And so we would sort of see these stories and talk about them together and think, kind of wring our hands like, why don't people get it? Why are these stories being reported on? And we realize well, folks don't know. Journalists maybe don't know about this. And so we have a real opportunity to, one, challenge some of the most common myths that we see come up again and again. So those are things like the difference between addiction and dependence, the fact that, what is the myth of quote unquote enabling? What is harm reduction really? The notions around punitive and coercive treatment. The myth about touching fentanyl, myths about babies who are born with neonatal abstinence syndrome, a lot of these sort of common tropes that come up again and again in the media. And so we decided we had sort of an all-day come-together retreat with dozens of people. It was amazing to meet people again from all sort of walks of life and profession and different ways that this topic has touched their professional or personal lives and passion, and think together about sort of, if we could challenge some of the most common myths, how would we do that? What are they? What's some of the language that's most concerning? And in addition to sort of offering up some education, could we offer up researchers and experts so that when a journalist is writing a story, they're often looking for someone to talk to. And if you're new to this space and don't necessarily know much about it, you're not going to have a sort of key go-to who may be an expert in the field. So to actually create sort of a list of experts that journalists could turn to. And so that work has continued. We've just started doing some podcasts actually ourselves about some of the core topics. And I think most importantly, it's just this amazing group of people who are passionate and working in the space and bring the wealth of multiple different perspectives to the table.
Yeah. Well, I want to ask you about a couple things you just mentioned. I want to talk about stigma and some of the myths, but let's start with stigma. So we know it shows up in a variety of places, media coverage being one of the places. I wonder if you can share some examples of maybe some of the more prevalent stigmatizing attitudes or language that you've seen around addiction in media coverage, and how do you think that reporters and the journalists working in addiction reporting can start to maybe shape or change that landscape a little bit and combat stigma through their own coverage?
Yeah, thanks so much for asking that. Language is so powerful and such a simple thing that we can all change, and that's probably the place to start. So many of the words that continue to be used for substance use disorder or addiction are incredibly stigmatizing and outdated. So probably the most common and one of the most problematic terms is the term abuse. So you'll often see terms like drug abuse or substance abuse or opioid abuse. And that word's problematic for a few reasons. First, it actually comes from a word that means a willful act of misconduct, a shameful thing, a violation of decency. And it makes sense if you think about what other terms do we use that word for. So it's things like domestic abuse, child abuse, sexual abuse, these very sort of violent acts of commission. There's no health condition that we would use the word abuse for. So if I were to say, my patient with diabetes is a sugar abuser, or my patient dealing with obesity is a food abuser, it would sound completely bizarre to use that type of kind of negative stigmatizing language for another health condition. So it really should have no place in our medical dictionary. And sometimes I think when we talk about this, people think, oh, this is just like being politically correct. What does it really matter what words you use? But words matter. And people have studied this empirically, that if a colleague of mine took highly trained clinicians, so master's and PhD level therapists, and gave them a description of a patient case, and the only thing that was changed was whether or not the patient was described as a substance abuser or as a person with a substance use disorder. And when the patient was described with a more stigmatizing language of being a substance abuser, the clinician was actually more likely to recommend a punitive treatment intervention than if the person was described as a person with substance use disorder, they were more likely to recommend a more therapeutic intervention. So words subtly shape us. They shape how we think about things. We're all can experience bias, of course, and words are one way that we sort of get primed to act in a more biased way towards people. So the term abuse, I think, is a great example of a problematic one that really needs to be retired. I think other problematic language are terms that label someone as nothing more than their health condition. So words like addict or alcoholic, which really imply that that's all that that person is. And again, to use an example from medicine, like I would never say I'm going to see the breast cancer. Like that would be a totally bizarre thing to say. I would say I'm going to care for Mrs. Jones, who's a retired scientist who is dealing with breast cancer or has breast cancer, because people are more than their health conditions. And so to never use words that really sort of narrow someone down to the only defining thing about them is that they are quote unquote an alcoholic. So those are some of the core ones. I think some other ones that are maybe a little subtler. One is the word clean. I think people often think they're saying a positive thing when they say, oh, this person's been clean for 5 years or whatever. But if you stop for a minute and think, okay, so we're saying clean, what's the opposite of clean? And what are we really saying about people who are actively using substances if we're implying that recovery is clean? And I'll always remember a dear colleague of mine who was a person in recovery was interviewing for jobs in the field, and he's very open about being in recovery. And he was relaying to me about how during the interview trail, people would say to him, like, so how long have you been clean for? And his reply was, I've been bathing since I was a baby. So I've been clean my entire life. And I've been in recovery for 10 years. And I thought that was just such a wonderful reminder of like, what are we saying with our language? We're using these terms that are for laundry or bathrooms to talk about human beings and their health condition. And so to really use medically accurate, appropriate person first language. So things like the person with a substance use disorder is in remission, just like cancer is in remission. And I think the pushback from journalists, one is sometimes just lack of awareness. Thankfully, many of the kind of manuals that journalists look to around like the APA style guides, so these manuals that give recommendations around appropriate language, have updated their language around substance use. And so that's helpful. Sometimes journalists will push back to say, well, it takes more letters to spell like person with substance abuse than it does to say addict. I sort of feel like that's a cop-out. If we were talking about another protected class of citizens or people, with a health condition, and there was an option of like a very stigmatizing word or a longer term that's medically appropriate, we wouldn't be having that conversation. So I think, that at its core implies that this is not the same as other health conditions. There's lots of shorthand that's very offensive that we would never publish in mainstream news outlets. And so just to stick to sort of medically appropriate terminology, I think is the best option.
Yeah. Let me ask you this too, because now I want to ask you about some of the bigger myths. And I thought this was pretty cool that the Changing the Narrative website has a whole section called The Tired Narrative of Drug Policy. And it's dedicated to a bunch of common misconceptions around addiction. And then it kind of busts them with data and facts that kind of prove the contrary. So I want to do a little bit of myth busting here with you today, Dr. Wakeman. What are some of the biggest, or, the ones that you see perpetuated the most? What are some of the biggest myths you read or see in the media related to addiction and substance use? And then can you bust a couple of them with for us, maybe sharing some realities that might be kind of helpful for journalists, especially to know when they're reporting on addiction?
Yeah, and I think one of the biggest that we see in the media, but also I think continues to be just perpetuated in what families hear and in some outdated treatment models, is this myth of kind of enabling or codependency, this idea that, is sort of interconnected with fallacies like practicing tough love, or that people need to hit bottom. And I think those notions are, first of all, totally false. And second of all, very different than how we would approach any other thing. So, I came to addiction medicine through internal medicine, and I would never say to my patient with diabetes, like, we're just going to wait for you to hit bottom and get your leg amputated before we start thinking about treatment. That would be absolutely bonkers. And any other health condition, the goal is to try to supportively work with people as soon and as early as possible in a very person-centered way that respects their dignity and their autonomy and engages in shared decision making. And so that those kind of notions that we're just going to wait for people to suffer some terrible calamity is completely backwards. But enabling and tough love are really tough because they are, I think, very commonly believed. I'm a person who had a family member with addiction, and very much our family had been told this idea that if you are sort of kind to the person in your family with a substance use disorder, if you're loving to them, that you're actually doing something harmful and that you need to kick people out of your house or refuse to see them or set all these limits or do a harsh intervention, and that that's actually a therapeutic thing. And this is perpetuated in shows like Intervention or Celebrity Rehab or all of these kind of TV shows that people have seen. And that couldn't be further from the truth. People get well when they feel loved and supported and cared for, when they have something to get well for, when they feel hope for the future. And I think, my colleague Maya Solovitz, who's a journalist in recovery who helped co-found the Changing the Narrative, she wrote this beautiful piece about the fallacy of tough love years ago that I read actually long before I met her and was so moved by, where she talks about, she never understood the fallacy of tough love, that she used drugs compulsively because she hated herself and she felt like no one, even her family, would love her if they really knew her. And so how would sort of cutting her down further to size or being harsh or kicking her out or sort of withdrawing your love be something that's therapeutic when you're sort of asking her at the same time to give up the only thing that has ever helped her feel okay in this world? And so I think it's just this totally backwards notion. And it also completely misunderstands the definition of addiction, which is compulsively using substances despite bad things happening to you. And so why would making more bad things happen to that person help them get well? And yet that's the dominant approach of much of our society. Like, what do we do for people dealing with substance use disorder? We kick them out of housing. We take their jobs away. We take their children away. We send them to prison. Like, these terrible things happen. And yet the defining hallmark is not being able to stop despite bad things happening. And we know, in fact, that it's really compassion and high quality treatment and partnership that will help people ultimately get well.
I want to ask you too, this was kind of another myth, and you touched on this before our interview when we talked about the perception of a one-size-fits-all approach to addiction treatment. Now, I've read that you cite 3 pillars of addiction care, and that's medication, psychosocial interventions, and recovery supports. Talk to me a little bit about this. Why is one size fits all inaccurate? Why doesn't it work? And why should individualized and holistic care kind of be prioritized? And how do you think we'll kind of tie it back to the media coverage, but how can that, which might be some new information to people, but how can that kind of inform a journalist's coverage of addiction?
Great question. I mean, so even now in the year 2024, I would say when people reach out to me sort of out of the blue to ask for help getting a loved one to treatment or accessing treatment for a family member or themselves, the number one thing people ask me for is quote unquote rehab. I think that is like the model that people have in their mind of what addiction treatment looks like. And we see that every day in conversations about where to dedicate resources to, this call for more treatment beds. We see it in sort of the entire model and kind of residential treatment model that has grown up. And it often is a very one size fits all model that, this pathway to addiction treatment involves a bed in a residential facility and sort of a one size fits all therapeutic approach. And if people aren't willing or don't find it helpful to engage in that model, they're blamed. They're sort of told that they're not motivated, that they're in denial, they're often kicked out of care. And yet, first of all, when it comes to opioid use disorder, there's no evidence that residential treatment is effective at all. But second of all, when we think about any health condition, we want to sort of take all of the evidence, what science tells us is effective, and then we want to personalize that to the human being in front of us. And so when we think about substance use disorder, treatment looks different depending on the type of substance use disorder. So that's the first way that a one-size-fits-all approach makes no sense. So my sort of toolkit for opioid use disorder is different than my toolkit for stimulant use disorder. And how, I approach alcohol use disorder is going to be different than how I think about tobacco use disorder. There are similarities, but each one is a little bit different. But I see my role as a physician in, much like any other health condition, understanding the evidence, understanding what effective treatment looks like, being able to make a clinical assessment of the person in front of me, and then being able to share that information with them so that they can make the best decision for themselves based on their own personal experience, their culture, their preferences, what goals they're working on. And my job then becomes to partner with them in that journey. And if things aren't going well, if they're not getting better, it's not because they've failed treatment, it's because the treatment plan has failed them. And so then the work, the kind of clinical work, becomes figuring out how to tweak the treatment plan together. And so that's true for any health condition, right? So again, using the diabetes analogy, I may think my patient should start insulin, but if they're terrified of needles, if they don't have access to a refrigerator, insulin may not be a reality in this moment for that person. I would never say like, well, you're clearly unmotivated, so I can't take care of you. I'm instead going to work with that person. And maybe we start an oral medication and we work with a dietitian and we do close monitoring and we see how much progress we can make towards that person's health goals, starting from the place that they're ready to start from. And so that really needs to be the model for addiction treatment too, that we need to make sure we're giving people the right information. Because I think, for example, with opioid use disorder, alcohol use disorder, most people, most family members don't realize how effective medications are, or that medications are a cornerstone of treatment. We need to be really thinking about the unique individual in front of us and their personal treatment history, their circumstances, their social determinants of health. And then we need to be partnering with them around that treatment, not sort of ramming this one-size-fits-all model down people's throats and then blaming them when they, for very good reasons, don't want to engage in every aspect that's being offered to them.
Yeah. I want to ask you one last question as we kind of come to the close of our time here today, and that's about the media and the journalistic side of addiction-based reporting, and if you could speak to them. So we've done a couple interviews with addiction reporters and talked about standards and practices for journalists in the field when it comes to properly and professionally kind of reporting on addiction. But I want to get some advice and recommendations from you in this regard. What do you think that journalists and reporters can do to kind of adequately prepare to get involved in this kind of new and emerging space, and how can they help make positive changes in the perceptions and language around addiction and treatment, moving forward for the future?
There's so much that journalists can do. And I think it's such a wonderful partnership because I'm never going to speak to millions of people across the country directly, but journalists can do that in their storytelling and their reporting. And that's often how people are hearing about the good and the inaccurate and the factual about addiction and addiction treatment. I think the first thing is educate yourself. So if you were diving into health reporting and you were going to become the cancer reporter, you would probably do a whole lot of research about cancer before you start reporting on it. I think sometimes folks who have no content knowledge in this space jump in, or they may have content knowledge in a very different area like crime reporting, and then all of a sudden they flip to addiction reporting. And I think just like any new field, especially a new field of science, I think coming in with sort of humility and wanting to learn and trying to immerse yourself in the science is a really important first step. I think, make sure that you're talking to recognized and reputable scientific experts if this is a health condition and an area of research and science. And so that's really important. I think I often use the sniff test of, would you approach another illness or another health condition this way? And if the answer is no, then you're probably on the wrong track. And I would say the biggest misstep I see in the addiction space and reporting is thinking of this still as a criminal legal issue and reporting on it that way. So you would probably never sort of ask a police officer their perspectives on the treatment of heart failure. Like, why, that would be sort of silly. Why would you expect them to have that body of knowledge? And yet I still see articles where journalists turn to sort of law enforcement as a main source of expertise around interventions to treat this health condition. And so I think, turn to the experts that have the knowledge to answer the question that you're trying to answer. I think always center the dignity and humanity of people who are dealing with this illness. There's far too much kind of voyeurism about the devastation of untreated addiction and bad drug policy. And there's not enough about the 24 million people living in lives in recovery in this country and how effective treatment is. And in particular, how effective medication treatment is. And I think that's hard because there is so much stigma. It's harder to find people who are thriving on methadone treatment or buprenorphine treatment who are willing to share their story. But those are the stories that we need to get out there. We need the average public to get to see what I get to see every day, which is people living these incredible lives, resilient, gritty human beings who have had their lives saved with medication treatment and are doing everything that, you know, their neighbor is doing and are just fine. And I don't think that's what we often hear when we think about the overdose crisis.
Yeah. Dr. Sarah Wakeman, it's been a pleasure having the opportunity to sit down and talk with you. Thank you so much for coming on and sharing your wisdom with us today.
Thanks so much for having me. It's been a great pleasure.
Thank you again, Dr. Wakeman, for taking the time to sit down and talk with me. There was just a ton of great information in this episode. I hope you guys all got something out of today's chat as well. And check out those show notes. We've got links to Changing the Narrative and plenty more great resources that Dr. Wakeman talked about today. If you or someone you know is struggling with addiction, we want you to know that you're not alone. Treatment is available and recovery is possible. Visit the link in our show notes to access patient resources like our physician directory, patient and family support groups, and much more. Thank you all for tuning in. We thank you for the support, and we will see you in the next episode.